In this skin infection lecture, we're going to cover the diseases that we didn't get to in internal medicine infectious disease. For a full complement of skin and soft tissue infections, check out this lecture as well as internal medicine infectious disease. Let's start off first with a strep infection called impetigo. This is a great picture question for the test. It's caused by strep and generally occurs in kids. So if you see a kid with a honey-crusted lesion on the face, diagnosis is done. It's going to be zoomed in on their cheek. It's going to be kind of yellow and crusty. That's strep. The diagnosis is clinical, and the treatment is going to be with amoxicillin. If it's refractory or they can't use amoxicillin because they're penallergic, you can use Clinda. There is an association with post-strep glomerulonephritis, but in the impetigo version of the infection, there is no risk of rheumatic fever. This is different when it comes to strep throat, where a strep infection can cause both. Another strep infection, this time usually in adults, is erysipelas. This happens in adults. Can happen in kids, but the vignette is going to show an adult that has this essentially infection of the lymphatics. So what you're going to see is the infection start distally and begin to ascend the limb in the lymphatics. So you'll see dark red, well-defined, indurated lesions that look like they're climbing up the limb. Again, the diagnosis is clinical. And because you've got a strep infection, the treatment is going to be with amoxicillin. And because the immune system of the adult is already robust, no risk for post-streptococcal glomerulonephritis or rheumatic fever. A big portion of dermatology is going to be taking care of acne. People care about acne a lot. Acne is caused by Propionum bacterium acnes. And you can use a lot of words to describe what happens, but basically you have sebaceous glands, hyperkeratinization, and colonization of a bacteria, which leads to this red, inflamed, nasty thing full of pus. So when you begin treating patients, what I want you to realize is that in practice, there's a ladder that you're going to climb, and you're going to increase up the ladder based on severity and failure of the things before it. But for the test, they're going to give you a description of terms, and if you find these words, you jump to the treatment. But in reality, no matter how bad the acne is, you're going to start at the foundation and work your way up. The first thing is topical retinoids. And you use this when the person just has a little bit of acne. Whiteheads and blackheads, comedones. If you have inflamed whiteheads or blackheads, or there's pustules, you're going to add benzoyl peroxide. But now as they begin to get really bad, that is, it covers a lot of the surface area, they are refractory, severe, nasty looking, you want to prevent scarring. So if they are severe, or they begin to be refractory to typical treatment, this is when you use antibiotics. The antibiotic you're going to use is doxycycline. And at the top of the ladder, the last thing you're going to use, isotretinoin. This is only used for refractory disease. And the only thing you have to remember to prevent harm is that if you're going to use the top of the line, the last-ditch effort, first get a UPT. Because the other treatments are topical, essentially, and antibiotics, while doxycycline is not good for baby, oral ingestion of steroids can really mess them up. So what you're going to do is essentially just treat them with skin stuff and then start advancing to oral as it gets really bad or refractory. We're going to close with tinea infections. And tinea is infection of the skin by a fungus. And depending on where it is on the body, they're going to name it something different. If you have it on the foot, it's called tinea pedis, also called athlete's foot. You're going to see red, itchy feet. You might see maceration in between the toes. And it will not get better on its own. So if you keep letting it go, there's a potential to have cracks and breakdown in the skin, leading to superinfections. The same infection is found in the groin, called tinea cruris, jock itch. Same deal, inflammation at the lining of jock shorts or underwear. Also going to be treated the same way as tinea pedis with topicals, topical antifungals. Tinea corporis is on the body, and it generally is well described, circumscribed, moderately scaled with central clearing. This is also treated with topical antifungals. I'm doing it this way to remind you which ones get topical. Basically, anywhere in the body that's not the extremes, you are going to treat with topical antifungals. The ones you treat with oral antifungals is onychomycosis, tinea inguinum, onychomycosis, and tinea capitis, as we talked about in the alopecia lecture. Tinea capitis should start with griseofulvin, and onychomycosis starts with terbinafine. All of these are essentially a clinical diagnosis, but because oral ingestion of antifungals is hepatotoxic, and you have to be on it for months to a year, you want to confirm the diagnosis with first a KOH prep. So in those areas that you are going to require oral antifungals, confirm the diagnosis first. If you're just going to use topicals, go ahead and treat empirically. So this sort of sums up the rest of the infections of the skin you have to know that weren't covered in medicine. That's skin infections.